Today we have, this is the second webinar. I would like really to thank the Saudi Commission for sponsoring and supporting these events, led by Dr. Ayman Abdu, Dr. Sulaiman Al-Umran, who have just left the Saudi Commission, and Dr. Yusuf Al-Shamri, who is assuming the responsibility of Dr. Sulaiman Al-Umran when it comes to the academies. And today we have a distinguished speaker, Dr. Joe Galagher, who has a very well established experience when it comes to multi-morbidity, cardiovascular disease in primary care. I think he will be the best, to give such a complicated topic. I'm sure will be simplified with the expertise. So if you can turn, please, if you can turn off or mute yourself, will be nice. You can, if you want to, turn on the video, that's fine, but please turn off or mute yourself. Or maybe Brian, if you can turn off or mute all of the participants until Dr. Galagher finish his presentation. Then we can open it for the question and answer. So the floor is yours, Dr. Galagher.
Thank you very much, Professor Abdullah, and thank you for the invitation to talk today, particularly on this, as you said, a challenging topic for us as family medicine specialists in managing multi-morbidity in primary care, and something that I hope we can come to some approach to together, because we all have a lot of experience in managing this, and we will all have slightly different approaches. And as I'll discuss, the evidence base for managing multi-morbidity is limited, and really it is the domain of the family medicine specialist, and we will develop further research and techniques as time goes on. I hope this will be an interactive presentation. I'm going to use a tool called menti.com, which is allows you to pose answers, and we'll show you a demonstration of that shortly. And as Professor Abdullah mentioned, feel free to pose questions using the chat function, or at the end we can interact online. So I'm going to start off by looking at using this Menti tool, which we'll use later on in the presentation, and then discuss what is multi-morbidity and how common is it, and why is it important to us as family medicine specialists, and then give you a technique for how I think someone could approach it. There is no definitive technique, and I would be very interested in hearing your approaches and what you might have found useful as well. And this is based on a number of guidelines that have been used in the United States and the United Kingdom, and trying to make them pragmatic and practical for use by us in primary care, and finally use two cases to illustrate how we might approach these cases and how we might implement that approach. So the first thing maybe I'll ask you, just to make sure that this Menti is working okay for us, is to using whatever device that you have to go to menti.com, which is on that there. And when you go there, you will see a code. So if you enter the code 519151, and this is really just a question to start us off and make sure it's working okay. What is the weather like today, wherever you are? That's the Irish answer.
كان windy.
So if you enter the code, yeah, there's someone who's sunny.
It's not so bad. No, I don't.
It's not windy. And let's enter any other. So we can come back to it again as we go on. There's some more coming on now, but you'll get the idea. And we'll use this during the presentation to discuss some of the cases and add answers. So great. Back to this here. So I suppose in terms of what multimorbidity is, it depends who you talk to. The National Institute of Clinical Excellence in the United Kingdom includes individuals with 2 or more long-term health conditions, whereas the American Geriatric Society defines as people with 3 or more chronic conditions. But the fundamental part of it is that it's people who have multiple chronic conditions, which may not even be in the one organ system. So yes, you may have multimorbidity, which relates to the cardiovascular system, such as having had a stroke and atrial fibrillation. But equally, you have multimorbidity where you have depression, heart failure, and osteoarthritis. There's a concept of complex multimorbidity, which is often defined as 4 more long-term conditions. And I suppose multimorbidity is a marker of healthcare burden. It's associated with polypharmacy, as these conditions are treated with many medications, and often overlaps with frailty as well, as the different organ systems are affected and people can become more frail due to this. I suppose we know that multimorbidity is more common as we get older, but it's important to recognize it's not just a condition of old people. So whereas here we can see that if you're over 85, you most likely have 6 or more chronic conditions. Even people who are less than 65, almost 30% of them will have 2 to 3 chronic conditions. So it is a problem that as we're living longer, we accumulate more chronic conditions. But even in younger age profiles, we are seeing increasing amounts of multimorbidity. And so it's a huge challenge to health systems and to healthcare management. This is just a graph showing how Saudi Arabia's population will age up to 2050. And as this population ages, we'll see a big increase in the levels of multimorbidity as people live longer and accumulate more chronic conditions. I suppose why it's important is that traditionally in our healthcare systems, we've had a single disease focus. So a patient with 4 conditions, such as this patient here, would have their conditions treated as separate diseases, often by multiple specialists with multiple treatments, with their decisions informed by single disease guidelines. And often there's very little integration between the conditions and the specialists involved. And the focus is really on the individual diseases when they go to that particular clinic rather than the person. So we deal with your diabetes at the diabetes clinic, your COPD at the respiratory clinic, your ischemic heart disease at the cardiology clinic, but there's very little reference to the other conditions. And that's a huge burden on people. There has been a sort of a trial of an evolution to the idea of comorbidity. And in this, same person with 4 conditions, and one is a dominant condition, that could be, for instance, ischemic heart disease. And there's an acknowledgement that there are other conditions there as well, but it's very limited integration. And so people may identify them and say, look, we'll manage your diabetes as well as your ischemic heart disease, but really it's sort of just recognize that this person has diabetes and may need to see a diabetes specialist. And the teams still tend to treat in parallel. There's limited contact, and the focus is still on the diseases themselves rather than the patient overall. But I suppose the ideal scenario is this concept of integrated multimorbidity care. And I think as family medicine specialists, we are the only group who can provide this, because we have that generalist focus to look at all these conditions, no matter what organ system they affect, but also the sociological aspects of it, as well as the biological and the psychological aspects of it. And so in this, there's a move towards focusing on patients' preferences and goals, trying to identify what does the patient want to achieve, and then building the disease guidelines around that. We integrate the care across the conditions, so we try and manage people as a whole rather than as a sum of diseases. And there's a multidisciplinary team, which family medicine is the key component. And so this is an example of a slide from the American College of Cardiology showing someone with heart failure. And it just shows they put heart failure in the middle here, and the gray lines show where there are positive actions. So for instance, the ACE inhibitor is helping the heart failure, but the orange lines are showing where there is negative interactions or potential negative interactions between all these conditions. And you can see how difficult it is. And if you take a single disease focus and a single specialty focus, you have all these specialties working independently to manage this patient, and everyone's getting confused. And so it's not surprising that we see that people with multimorbidity have a lot of fragmentation of care and poor coordination of care, and they can fall between cracks very easily. There's polypharmacy, where they're on multiple medications, often out of consideration of how they might interact with each other. And there's a treatment burden associated with that, where they can feel overwhelmed. Unsurprisingly, a third of people will have mental health difficulties associated with their physical chronic conditions, and then functional difficulties as frailty develops can lead to problems in functioning in everyday life and economic difficulties. This leads to reduced quality of life, and eventually you're going to get this increased healthcare utilization, where there's sort of shuttling between different specialties, ending up in the emergency department, because no one person is really coordinating their care. That's really where family medicine can come to the fore, and if resourced properly, can actually give very good care for this group of people. And so traditionally, family medicine has been seen as one of the specialties that manages all these people. But in reality, our health systems across the world need to reorientate so that family medicine is at the center of looking after people with multimorbidity. And the other specialties all provide advice and are very valuable parts of the care of this person, but family medicine is at the core of the management of this person's healthcare. The challenge in doing this and managing multimorbidity is that we have very limited evidence as to what multimorbidity and what works. Patients with multimorbidity are not involved in many clinical trials. They are difficult to manage, and they're also difficult to examine in randomized controlled trials. There are so many variables that come into the mix that clinical trials like to exclude them. So therefore, the guidelines that we use to manage their chronic conditions, such as heart failure or diabetes or ischemic heart disease, are based on populations that are not like the people we see in practice in family medicine. Not only that, even if you do take into account the different physical health problems that may coexist, such as diabetes and cardiovascular conditions, there's often a lack of recognition of the mental and physical health problems that are coexisting. And as I mentioned before, a third of patients with multimorbidity will have a coexisting mental health condition. And again, family medicine specialists are one of the few groups who will actually take that into account. Outside of that, the experience of the patient and their carers and family and the impact of these conditions economically on people are often overlooked, and how that impacts on people's ability to actually access healthcare and to actually manage their day-to-day lives. And as we mentioned, because of this often single disease focus in health systems, patients with multimorbidity often have a less continuity of care than patients with a single condition. And there's a real need for that system redesign to bring that focus onto the patient and their goals and primary care and family medicine rather than the diseases overall. This is just an example showing how difficult it can be to apply guidelines to the patients we see in family medicine. This shows on the left here the number of patients who have another chronic condition along with the one in the center. So for instance, 91% of patients with coronary heart disease have another chronic condition, 78% of people with hypertension have another chronic condition. But in the studies and trials that are used to develop the guidelines, 69% of trials for coronary heart disease exclude people with other chronic conditions, and 87% of trials in hypertension exclude people with other chronic conditions. So it makes it very difficult for us in family medicine to be sure that these guidelines will work well among people with these conditions, and it's a challenge for us to integrate that into our daily practice. Because of the limited evidence of multimorbidity, when we look to find what are the best approaches, there is very little out there. This is a Cochrane review that was undertaken, and it just highlights that overall the results of this Cochrane review of the effectiveness of interventions for multimorbidity were mixed, and that indeed they found no clear positive improvements. And that doesn't mean that things can't be done, it just means it hasn't been studied, because the focus has often been on single diseases rather than multimorbidity. This is just an area of possibility. As I mentioned, it's very challenging to study multimorbidity in a randomized controlled trial because there are so many different groups, so many different combinations of diseases. There's real interest now in using artificial intelligence to try and identify clusters of conditions in multimorbidity that may allow us to develop approaches to studies to better manage these patients. So for instance, this study from Newcastle, looking at people over the age of 85, identified 5 clusters of chronic conditions that tended to cluster together. So for instance, the one I've shown here is the cardiovascular one, which does have cardiovascular conditions such as hypertension and heart failure and atrial fibrillation. It also includes things such as asthma, thyroid disease, diabetes, cancer, and renal impairment. And so perhaps we could include these groups as cohorts in studies to try and figure out how might we manage this population. Well, it's all very new and something that's developing in the future, and certainly be something that will be of great interest in the coming years. But I suppose practically, the reason we're all here this evening is to figure out what can we do in practice today, and how can we best as family medicine specialists manage patients with multimorbidity. I think the key part of this is that we're part of a team. You know, the patient is in the driving seat, like in this Formula 1 car. We have all the different specialty teams focus on their part, where it's the wheels or the brakes. But the family medicine specialist is the pit team leader who's ensuring that all this is working well together. And if we could get this sort of system working, well, I think everyone would have a much better outcome. But that is much easier said than done. You know, just coming back to again, our focus in family medicine is on integrating all these conditions together, focusing on the patient's preference and goals, and leading a multidisciplinary team where family medicine is at the center of it all. So there are many guidelines out there on multimorbidity, and for instance, the one from the United Kingdom is 264 pages long. The Americans have a similar long one. Trying to get that into an hour-long session would be very challenging, and I think it shows how difficult it is to develop anything to manage multimorbidity. But as family medicine specialists, we don't have time either to be reading such long documents. So what I've tried to do here is take a selection of some of the approaches that have been suggested by different expert groups and apply them to what might work in a family medicine setting. And so this isn't the only way to do it, it's just a suggested approach, but hopefully you'll find it of use in approaching patients who attend you with multimorbidity. So as we mentioned, the key part, I think, in multimorbidity is looking at what are the patient's priorities themselves, because that sets the goal for you. It allows you to decide where do we need to go and what do we need to focus on today. I think then secondly, it's important to consider what's the patient's health trajectory? What do you think their life expectancy might be? And then that helps us look at what is the time to benefit of treatments. If we believe that someone has a limited life expectancy of a year, there is no point starting a treatment that takes 10 years to have a benefit. So that helps us guide what treatments might be important based on what the patient's priorities and what their health trajectory is. And then it's important to think about what are your priorities. Patients don't come to us and say, I want to have anticoagulation for my atrial fibrillation, or I think an SGLT2 inhibitor is best for my diabetes. They come to us with their priorities, but we'll have our priorities, and then we can work with them based on their priorities to identify what treatments will work best to achieve their priorities. So working together, we can decide what to do, and then we align our goals to try and achieve the best outcome for that person. That mightn't always mix with the guidelines that are out there, because what the patient's goals are and your goals might not work together too well, but often we can bring things into a solution that will work well for the patient in front of us. And as family medicine, our focus is always on the patient in front of us. I think it's important to share with both family and patients themselves that our evidence base for evaluating treatments in patients with multimorbidity and frailty is very limited. And so therefore, when they're reading about guidelines or headlines on the internet, that it's often to very select populations. And often sharing that with people can be very liberating for them, where they sort of feel, well, now I understand why I'm not having this treatment, and they can understand what the side effects and the problems may be with it. And so sharing that, I think, at the start and saying, we're not clear sometimes how this will work for you can be very helpful. In terms of the patient's priorities, I think it's about asking them. And I think if we ask patients what are their priorities, they often won't quite know what we mean. They're not used to us asking what are their priorities. But I tend to use some phrases like, what does a good day look like for you? Or what would you like to be able to do? Because that sort of sets up for us what are they actually really concerned about on a day-to-day basis. Is that getting to the shops? Is it being not in pain? Is it their breathing is the problem? Sometimes it's a worry, what worries you most? What are they most afraid of? That really can open up a whole range of things to guide us as to where we need to go. As an example, just yesterday, I had a patient in the practice where I was looking at their diabetes and worried about their HbA1c. But when I put this question to her, her problem was her ankle arthritis. She couldn't get out of the house with her ankle arthritis, and that was stopping her walking, exercising, getting to the shops and eating properly. And if I had just focused on the HbA1c, I would not have achieved very much. So it's really important that we put this up front and center. In the patient's health trajectory, sometimes it'll be very obvious. Someone who's 50 and maybe might have asthma and hypertension and is otherwise well, this might be something you don't even need to ask or think about. It's straight in front of this person will be fine. But you may have a patient where you're not quite sure how they will do over the next while. Sometimes it can be useful to ask them, where do they think that the next 6 months, a year will be for them in terms of their health and function? I'm often surprised by the answers that they come back with. Some people vastly overestimate what they think they will achieve, others underestimate their prognosis. So that's important. Some of you may have seen this, what they call the surprise question, which is where you ask yourself, would you be surprised if this patient died in the next year? And if the answer is that no, you wouldn't be surprised if they died, we should think about, are there approaches? Should we focus more on symptoms? So depending on the patient, this might be a very important question to ask yourself and ask them as well. And then in terms of what are our priorities, I suppose we're often in medicine very focused on guidelines, and they are very useful. They're a very important part of our practice, and they certainly give us guidance as to things we should think about. This is a useful guide, I think, from the Journal of the American Geriatric Society, looking at when are disease-specific guidelines applicable. So certainly if someone has a long life expectancy, has few conditions, and is functioning well, yes, guidelines can be very applicable. At the opposite end, if someone has a very limited life expectancy and has advanced or end-stage disease, they may not be applicable at all. You may focus on symptoms. And the majority of patients in family medicine will often sit in the middle with a life expectancy which is relatively long, but having an increasing number of severity of conditions and some impaired function. And in this, we may need to pick and choose from the guidelines, depending on what we feel will work best to achieve the patient goals and the best outcomes for the person sitting in front of us. So I think having taken all that into account, and as I said, the important is to acknowledge uncertainty sometimes and share with the person that, we are going to try some things here to achieve the best outcome for you. And then thinking about what sort of treatments might we want to stop or not start. So for instance, if you had someone who had recurrent major bleeds and anticoagulants, you may want to talk to the specialist teams involved or with the family about, is this something that people should continue? I had one person who got nosebleed and saw the otolaryngologist, then saw a gastroenterologist for their GI bleed, but no one really was going to take on the task of discussing that point about, well, should we be continuing this? And sometimes the family medicine specialist needs to raise that issue with the person and the family and the other specialists to consider these multiple events that are happening. There are some tools which you can use to look at what medications might be inappropriate in older adults in particular. So there's the stop-start criteria, the De Beers criteria, which look at drugs which might not be appropriate for older people. And then you can often discontinue treatments that might be no longer indicated or needed. Sometimes you find someone has been started on a treatment, for instance, a proton pump inhibitor is a common one, back 3 or 4 years ago, but in actual fact, they may not have a need for it anymore, and therefore it may be possible to start it. And also sometimes patients can be very concerned about the task that we have given them. So for instance, in Ireland, we often tell patients to weigh themselves daily in heart failure to see are they gaining fluid, but that may not be appropriate as they become more frail or older and may not be as beneficial. And sometimes saying to the patient, you don't need to do that anymore. We can check that some other way is useful, and it takes that burden of worrying about having to weigh themselves and keep an eye on it every day off them. It's all about tailoring it to the patient in front of you. I suppose in terms of aligning the patient's priorities with our priorities, it's important to link the decision to something meaningful to the patient. So I think often if you take something like hypertension, for instance, if we say we're going to treat your blood pressure and the patient's worried about, I want to be independent and be around to see my grandchildren, they don't see the link between the two. But sometimes if we say to them, listen, I want to treat your blood pressure because we want to prevent you getting a stroke and getting heart failure, and that will keep you independent, they would understand much better why we're treating this condition, even though they don't feel unwell. And so I think it's trying to link their priorities to what your priorities are and make them see why it's important. And that's why we need to focus the discussion on the patient's health priorities, not only on the diseases. People are worried about what they want to get done, not particularly about the disease that we're worried about. Also important to ensure that the patient's health outcome goals are consistent with their healthcare preferences. So taking, for instance, that example of hypertension, if someone's saying, I don't want more tablets, I don't want treatment for my high blood pressure, but yet saying, I'm worried about having a stroke, it's about linking that and saying, well, look, this is why we need to treat your blood pressure, to prevent that stroke, and not just giving you tablets to get your blood pressure low. It's to prevent something in the future. There might also be some aspects of treatment that might be causing difficulty, and we'll talk about that in one of the cases. For instance, diuretics can often make it difficult for people who have to travel someplace. They find it difficult to get out. And there are some tips and tricks we can use to help them manage their life while still taking appropriate medication. And sometimes we can be hard to accept the patient's decisions. And it's important that to record your reasons for them and the discussion. Because as I said, sometimes the guidelines won't apply, or even applying the guidelines can cause problems. So recording why you did something and what the patient's perceptions and what their concerns were can be very helpful in revisiting it later and saying, well, this is why we did this and this is why this happened. So I'm going to just take two cases as examples maybe of how this approach might work in practice. This man has a range of chronic conditions, both cardiovascular, rheumatological, diabetes, and depression, and is on a range of medications also. He's never smoked, his BMI is normal, relatively physically active, and he's had no recent vaccines. He's short of breath when climbing hills, but that's been stable for years, and it doesn't cause him much problems overall. His pulse is 68 beats per minute and regular. Blood pressure is 166 over 88 millimeters of mercury. He had an ECG recently, which showed that he was in sinus rhythm with left ventricular hypertrophy. And his echocardiogram 1 year ago showed he had an ejection fraction of 40%. Putting all those together and his blood test results, this is the type of pattern we see. So I'll get you to go back to menti.com now and put in that code. And I want you just to tell me, what sort of things would you be worried about? If you were the family medicine specialist, what are your priorities in this? What are you actually really thinking you need to deal with this person? Good. So we can see, there's a variety of things that people are concerned about. And that's a challenge, because when we talk to Abdul Latif, he says, what's a good day look like for you? He likes playing with his grandchildren, finds it hard when he gets short of breath and his knee hurts. He'd like to be able to do more with them. He's really worried about his breathing getting worse. Is it going to get worse? And will he lose his independence? And I'm not sure about Saudi Arabia, but in Ireland, the commonest question is, can I reduce the number of tablets I'm on? Everyone wants to get off tablets if they can. Would I be surprised if he died next year? I think I would. He's been stable otherwise. He's out, physically active. So he has a relatively good health trajectory, and we'd really want to optimize that. And when I sort of looked at this earlier, I took his priorities, which were his shortness of breath, the knee pain, staying active, independent, and reducing the number of medications. And then what would be my priorities maybe if this was the sort of person who came in? That is a long list to try and deal with in one appointment. And across multiple specialties. And it's the real challenge of family medicine. How do we marry all this together? I suppose in terms of time to benefit, this was an interesting sort of slide I came across. He wants to improve his symptoms and his prognosis. And what sort of things improve prognosis and how long does it take? So this is an example just of some common medical conditions and how long it takes to have a benefit from treating them. So hypertension, the outcome of mortality, heart failure and stroke, needs a number needed to treat of 50 to prevent one event. Only takes 2 to 3 years to have that effect. And the risks of having bad side effects are low to moderate. Heart failure with reduced ejection fraction, like this man with ejection fraction of 40%, even shorter, only months. Treatments such as ACE inhibitors and beta blockers within months will reduce their risk of hospitalization, reduce their mortality, and improve symptoms. Something like diabetes, it might take a lot longer to, blood sugar control, could take a lot longer to actually have an effect. It could be 10 years of managing their blood sugar to prevent things such as diabetic retinopathy. So it's useful to think of these as, what are we trying to achieve? So this is a sort of technique I'd heard talked about before called lumping. It's trying to take the conditions not as diseases on their own, but in terms of the patient priorities and putting them together and then trying to break them off into different consultations. It would be impossible to try and deal with all these problems in one consultation. And it just wouldn't work. So taking these are the ones in blue for Abdul Latif's concerns, the ones in green would be my ones about his care, and we can break these into 3 major groups. So for instance, if we take staying active, knee pain and breathing, really his hypertension, heart failure and osteoarthritis are part of that. To stay active, we need to treat all of these: hypertension to prevent his stroke, heart failure to improve his symptoms, and osteoarthritis because he's got his knee pain, and that would also help his breathing also. So we might decide to tackle that over 1 or 2 consultations and try and optimize those treatments. His other problem was he wants to reduce his medications, and then, so well, his lipids weren't great. He's on citalopram for a while. Does he need to continue on that? And his ischemic heart disease medications. So we might decide to tackle that next and say, right, I believe we will get this right, get you feeling a bit better. Then we will look at your medication, see can we rationalize those better. And then based on that table where the HbA1c, yes, was elevated at almost 9% or 75 millimoles per millimole, but that's something that we can keep for a little while and give it some time And once we get these sorted and improved, then we will see, then we can tackle that. So by breaking this really complex set of problems into sort of 3 major groups, we can tackle these bit by bit and try and achieve a better outcome for Abdul Latif, and also improve his symptoms and improve his, his perception of his healthcare by reducing his medications. So how does it look here? So this is a patient of mine. I would have, sent him to physiotherapy. We're considering, does he need orthopedics? If he had moderate severe osteoarthritis and pain wasn't manageable, then that might be worth looking at as well. We changed his cholesterol tablet to get his lipids better under control. And then because of his heart failure, we restarted his frusemide. And looking at that, that could have dropped off before, could have been stopped by accident, and put him on an ACE inhibitor and a beta blocker. That will improve his symptoms and his outcome. And then we were able to stop some of the medication. So I mentioned we stopped the simvastatin, but we swapped that for another one. He was on clopidogrel with aspirin, and that seemed to be something that was kept on the prescription after his stent was put in 5 years ago, and that could be stopped safely when we looked at it. And finally, his mood had been very good. He'd been on citalopram for 10 years. It was possible to stop that also. So this is done over a long period of time, not just over one consultation in 10 minutes, but by breaking it down, we can sort of approach that bit by bit. So this is the second case. It's a lady who has a lot of chronic conditions, not dissimilar to Abdul Latif in terms of cardiovascular, diabetes, and also osteoarthritis, on a number of medications as well to try and manage these. She lives with her husband and son. She needed to use a frame because of a knee pain. She's had 3 admissions to hospital in the past year and had to go on non-invasive ventilation on her most recent admission also. BMI is slightly up. As I mentioned, she's limited mobility. She's recently had vaccines and they're all up to date. This is her pulse, 88 beats per minute and regular. Blood pressure, a little bit on the low side at 104 and 72. She has chronic kidney disease. She has excellent lipid and HbA1c control. I suppose, again, putting all these together and looking at it, what are your priorities for Miriam? So we might go back to menti.com again. And I'll just set it up here. So again, the code is 519151. So you can see here, much more complicated case, a lot more going on. This is what I'm sure it feels like in the consultation when you see someone like this, all these words coming at you, all these different aspects to look at. Which one do you choose and how do you approach it? So well done on spotting all of those. So let's go back to that approach again. What are her goals? She doesn't want to be short of breath. She gets very anxious about it. She doesn't want to go back to hospital, doesn't want to die in a machine. She has so many appointments, she's overwhelmed. She's really worried about her breathing getting worse and having more pain in her knee. And again, she's worried about her medications. And interestingly, she mentioned that she has to get up a lot to urinate at night with the diuretic tablet, but if she doesn't take the tablet in the evening, she finds it hard to sleep with her breathing. So these are her concerns, which ally with the ones that we've all mentioned here, as we saw on the word chart, but how she expresses them is different. What's her understanding of the trajectory? She says, I'm not sure I've long left. I want to spend time with my family and not with machines and tablets. And when we look at this ourselves, would we be surprised if she died next year? The answer is no. We probably wouldn't. Hope that she won't, but if something we could see that something could happen, that she could suddenly deteriorate. So the priority list here is quite long. Her priorities are really on her breathing, anxiety. She wants to be able to stay at home, reducing the number of medications, reducing hospital appointments, and pain. We're looking at things such as her atrial fibrillation, her renal function anticoagulation, her shortness of breath, her arthritis, her glucose control, her blood pressure. And again, with that question, could she, given her goals, is this something that we need to discuss palliative care with and discuss her about it? Again, her aim is to improve symptoms. You know, she doesn't, prognosis isn't as much of an issue. We're not trying to prevent something in 10 years' time as such, particularly if it's going to cause a lot of side effects. So we need to balance all those things together. So here's her list. Her medications in blue, or her priorities in blue, our priorities in green. Again, using this sort of idea of lumping these together, this is what I've sort of looked at. So, you know, I'm thinking of, do we need to discuss palliative care with her? She's looking at reducing appointments, staying at home, and avoiding hospital. That's a complex decision that will involve her, her family, and the specialist she attends as well. But we might be the only people willing to bring it up and discuss it. Her heart failure is causing anxiety because of her breathing, and she's having to get up at night with the urine. Her osteoarthritis is causing her pain, and she wants to reduce the number of medications. And we know that her blood pressure was actually on the low side, and her HbA1c had excellent control, which might provide an opportunity to do that. So again, picking these off in groups and deciding to maybe prioritize one at certain consultations might allow us to approach this better. So with this lady, what did we do? You know, after discussion, you know, stopped her atorvastatin. It's a long-term, she was using it for primary prevention. It's a long-term, drug in terms of it takes a number of years before we see an effect from it. She decided she would like to reduce her medications and stay off it for a while, and maybe if she does better, go back on it again. We noted her chronic kidney disease was making her at risk of bleeding from her anticoagulant. She was on one of the direct oral anticoagulants, apixaban, so we reduced that dose. Her blood pressure was low, so we actually stopped her blood pressure tablet, and we stopped her diabetes tablet because, again, her blood pressure was on the low side. HbA1c was almost too low. That wasn't something we really wanted to manage at this time, and she was burdened with medications. We stopped her diclofenac, which could have been impairing her kidney function and making her heart failure worse. We gave her a joint injection for her knee, which helped, and she was able to manage that with paracetamol. She was getting frusemide at 3 times, 8 a.m., 2 p.m., and 6 p.m. But in actual fact, we were able to stop the 6 p.m. dose and give her a nitrate patch at night to help with her shortness of breath. And finally, we were able to reduce her lansoprazole to 15 milligrams. And in actual fact, we might be able to stop it over time if she's doing okay on that. And finally, we spoke to her about her breathlessness and her anxiety. And in a consultation with the palliative care team, we started alprazolam that she could use when she needed for her shortness of breath. Nothing we'll see in guidelines, but did help her dramatically with her symptoms. And so I had a patient very like this in our practice, and one of our family medicine registrars did a study looking at how people manage. And doing things like this, although they don't fit with the guidelines, actually made a huge difference to this lady's life. And she said, I feel that if I needed to see someone, I wouldn't have a problem. It gives me great peace of mind. I would come to the practice first. My symptoms have improved so much. I've been at home with my family and I'm not as scared anymore. And I suppose that's the great thing about family medicine. By doing these things, we can have a dramatic impact on people's quality of life and their symptom control. And that's really important. And that's, I suppose, what we're often here for. But I think it's also important to remember, as family medicine specialists, we have a dramatic effect on mortality also that may not be reflected in guidelines. And this was an interesting study from the United States that showed that every 10 additional primary care physicians per 100,000 population was associated with a 51.5 today increase in life expectancy, whereas an increase in 10 specialist physicians, which corresponds to a 19.2 day increase. So it's a really exciting time to be in family medicine. We're really at the forefront of healthcare. We are the people who will be able to manage these group with multimorbidity. There is emerging evidence on how to do it. And this is just one approach, and you'll have many other approaches that you could use, but I hope that may be of help. Of course, we can't always do it on our own, and this is just something that I was asked to talk briefly about in terms of, how can we better integrate with our specialist colleagues as well. This is a technique we use in Ireland where we use web conferencing to discuss cases, in this case about heart failure. People with heart failure have high rates of multimorbidity. On average, they have 5 chronic conditions or on 11 medications, and they find it very difficult to travel to the clinic. But yet they're a complex group, and often we need the heart failure specialist advice. This is using web conferencing to discuss those cases, and the specialist can give advice to the family medicine team as to how they might best manage that patient without the patient having to travel to the actual outpatient clinic. With this technique, 93% of people could be managed in the community without having to see the specialist in person. And when we asked the family medicine specialist what would they have done out the virtual clinic, almost 90% would have ended up either sending to the emergency department or outpatients. And I'm aware that in Saudi Arabia, there are new apps being developed as well that allow patients to interact with you and do online prescriptions also. I think this will be part of the use of technology, where it's used to help coordinate care better and reduce the burden on patients in traveling to see people in person. So I suppose in summary, multimorbidity is becoming increasingly common, particularly as the population ages, but it's still a common condition in younger people also. I really believe that family medicine is the group most needed to tackle this growing problem. We are one of the few last generalists who are left, and so our skill set will become crucial in tackling all of this. In terms of structuring a consultation for multimorbidity, I tend to start with the patient priorities, then look at the prognosis that I think this patient has, and then think about what are my priorities based on those. Then try and align my goals with the patient's goals and also that of the family and carers. And then taking all those, try and lump them together into things that are with the patient's priorities, and then spread it over a number of consultations. You can't do this in one go, you'll just get overwhelmed. And I was saying that last time, multimorbidity, it's a marathon, not a sprint. You will be with these people for many years, and so you can take your time to achieve the outcomes. And sometimes you'll go forward a step, and sometimes you go back, and you'll have to make some other changes to try to get back on track. So it's important to share that uncertainty with the patient, that it's not definite, guidelines don't always apply, and that by focusing on their priorities, we will make progress together as patients and doctors. It's just a reminder that there are similar complex sort of patient cases on the online platform. I was involved in developing the arrhythmia modules on hypertension, arrhythmia, and heart failure, and you'll be able to discuss these on the discussion forum also, and share your experiences of managing these patients, because everyone is an expert in managing these in family medicine, because there is no one guideline for any of these people. So thank you very much for listening and your participation, and I'll hand you back over to Professor Abdullah for any questions or discussion.
Thank you very much, Dr. Galagher. Excellent presentation. Practical, simplified approach to a very complex medical problem. I think key messages include the fact that we have to be patient-centric, we have to focus on quality of life, and we have to be comprehensive, which is the basic, principles of family medicine and general practice. Thank you very much. Any question from the audience? We have, good crowd.
There was one earlier on. There was one question earlier, Joe. Somebody was asking, like over one long visit or multiple different short visits. But you've answered that question. It's multiple short visits, really, isn't it?
I think it's easier, Tony. You're right. I think even for patients and carers, changing too much at one go can just be overwhelming, and for us as doctors, it can be overwhelming as well. I think if we can structure it over shorter visits, it'll work better and gives us time to evaluate.
Yeah.
What do you think, Joe, in terms of the timing of reviewing, medications and the assessment of the patient in general practice? How often should we do it?
So it's a very good question, Abdullah, and I think we all challenge. I think for people who are well and are on a small number of medications, often we would see them maybe once every 3 to 6 months, depending on how they're doing. But then for other people who are on multiple medications or where we've had recent changes, you may see them, every month for a period of time. And I think you sort of find that people move in and out of it. They start on medications and you're checking to see how they've got on, and you see them frequently for 2 or 3 visits. And then when they're doing better, they settle down into a more, longer span, maybe of 3 to 6 months. But I think certainly wouldn't want to go beyond 6 months, and the more complex a person becomes, the more often we end up having to see them, particularly when their conditions change.
Great. Just a note for everybody, polypharmacy is which is somewhat related to multiple medical or comorbidities, is very common actually in our practice. Several papers actually were published around this issue in Saudi Arabia. 50% of our patients actually they take 4 drugs or more. So this is, we talk about a very common medical condition, and comorbidities, 2 or more medical problems. They represent around 40% of our patients, based on several papers from multiple, different regions in Saudi Arabia.
It's a similar problem here as well. We have large numbers of patients on multiple medications, and I think the e-prescribing initiative that you described earlier will be helpful in trying to centralize patients' records so everyone knows what medication someone is on and why they're on it.
Great.
I have a question.
Okay, go ahead.
Sorry, Tony. I have a question here from user. Just finding that sometimes elderly patients psychologically hang on to the medication, and it's difficult to convince the patient that it's unnecessary. Have you any tips or comments on how to approach that aspect?
I think it's very true. Someone who was unwell and started medications and felt better is always understandably worried that if you stop the medications or reduce them, that they will become unwell again. And so I think it's about trying to align it with their priorities. So if they're sort of, having falls and saying to them, listen, you're having a fall and this may be related to this medication, and we will stop it for a little while or reduce it. But, that doesn't mean you're off it forever. If this doesn't, work as well as what we think, we'll restart it again. But I think this will make it better for you and what you're trying to achieve. So I think there's 2 aspects. One is linking it to what their concerns are. Whether that's to do with the, that they will get worse, which is, look, we have ways we can treat that, we will reduce it. If you feel you're getting worse, we can increase it back up again. Or if they're having side effects from it, linking it to the side effects. And then also saying to them, this is something that the privilege we have in family medicine is that, we're not sending them off for 6 months or a year, never to be seen again. We're in their community, they can come back to see us, and you build in that review and say, look, we'll see you in a couple of weeks, we'll see how you've got on. And if in the meantime, you can contact us if there's any problems.
Great. Any question from the audience?
No, I suppose I just an observation. If nobody has a question, we've been going to Saudi Arabia for the last number of years, and it's an exciting time. Primary care, on family physicians delivering the care in the primary healthcare centres, and we are the only people who can coordinate all the information and all the clinical data on the patient. In my own experience there, just during the week, I had a multi-morbid patient with diabetes that I've looked after for over 30 years, and I could see that his renal function had declined, that I needed to reduce his apixaban, half the dose. I needed to reduce his sitagliptin, his DPP-4 inhibitor, but nobody else. He was seeing cardiologists, he was seeing stroke specialists, he was going to heart failure clinics, yet nobody had put all of that together to make those important adjustments to his medications for his safety. So, we're in a very privileged position, and we really, we should be proud of what we can achieve and what we can do to help keep our patients healthy and well and at home. And so, it's an exciting time, as you said, to be a family physician.
Totally agree.
I have another question here from Dr. Ali. What about drug-to-drug interaction, where he has to describe both aspirin and I think it's clopidogrel?
Yes. Yeah, so I think that it's a real problem. We have drug interactions, we have drug disease interactions, and it is about being careful. And I think particularly as Tony, as family medicine specialists, our role is we have an overview, and a cardiologist may start a drug for one indication, but we may have to go back to them and say, listen, you do realize this man, so this happened just during the week with me, a man who had a large pulmonary hemorrhage only in October and was under respiratory, was started on apixaban by cardiology. And I had to ring them and say, listen, this man was, almost bled out before in October, and they hadn't realized, didn't have that information. So it's important that there may be drug disease interactions, and the same with drug interactions. Our software here sometimes warns us about drug interactions, but you get so many warnings it can become overwhelming as well. So I think it's important just to have a few key ones in your mind. And if you sort of see someone start on drugs and you're not quite clear why it is, and you have concerns, do share it with your colleagues or with the specialists who started it, because more often than not, you'll be right, and they will sort of have to adjust things from what you've spotted.
And with the electronic medical records, now we see more utilization of the e-prescribing softwares. And in our country, we have one of these apps. I think it's locally developed. It's called Wasfati, My Prescription. Unfortunately, it actually highlight and send alert, for some of the potential interaction of certain drugs. So it helps.
Yeah, absolutely. It gives us a flag. I think it's important.
Any other question from the audience? Okay, so if we don't have any more question, I think we can close the session. Thank you very much, Dr. Galagher, for the excellent presentation. Very practical and simplified approach to a very complicated and complex problem. I think key messages are family physicians, so we need to focus on comprehensive care whenever we take care of such patients. Again, thank you very much, and see you all soon in the next webinar.
Thank you all very much for participating. Thank you.